education. So we are thrilled to global audience with us today. Join us not only from mainland China, but also from India, Europe, US, and South America. So we are honored to have you all here with us today. So Dakewe is proud to be the leading brand in the Chinese pathology device industry. So with our products being used all over the world. So as part of our commitment to the field of pathology, so we have established a platform for knowledge exchange. So this will allow pathologists from different countries to learn from and share practical experience with experts in the field. So we are excited to have Dr. Prabal Deb from India's Aster Labs as our lead presenter for tonight's webinar. So he will be sharing his extensive knowledge and experience in the glioma pathology. So we are also pleased to have Dr. Jianying from the Department of Pathology at Sunny Downstate Medical Center as our moderator. So we appreciate both professors for attending and sharing their experience with us. Okay, so next we would like to invite Dr. Zeng to start host tonight's webinar. Dr. Zeng, please.
Okay. Hi, everyone. Today is a great opportunity that Dakewe invite Dr. Prabal Deb to give us a talk. Dr. Deb is the head of operation and technical head of Aster Labs in India. The director and senior consultant histopathology of Aster Global Reference Lab at Bengaluru. He's also a specialist of anatomic pathology in Medicare Hospital at Dubai, professor and director of tumor pathology course in Aster International Institute of Oncology. Dr. Deb is an astute pathologist with 3 decades of broad-ranging expertise in profession, academics, research, and administration. He has extensive experience in conventional as well as cutting-edge techniques in laboratory science with specialty interest in oncopathology, neuropathology, dermatopathology, and cytopathology. Dr. Deb received his medicine and pathology training in Armed Forces Medical College in Pune and was selected by Armed Force to have 2 years of specialty training in neuropathology, followed by molecular neuropathology fellowship in University of Heidelberg in Germany. Dr. Deb has practiced in pathology for almost 30 years and was the specialist in oncopathology and neuropathology. He's also the professor of pathology since 2013, teaching undergrads and postgrad students. His primary focus of neuropathology is brain tumors, especially molecular pathways in glioma genesis. Dr. Deb is very productive. He has published 94 peer-reviewed articles with high citation rate, 24 book chapters, and is the editor-in-chief of Journal of Cytology. He has received many honors and awards for his excellencies in research and contributions in pathology. So today we are very fortunate to have Dr. Deb to give us their talk, and he's going to speak about morphology to molecular diagnosis, paradigm shift in diffuse infiltrating gliomas. So let's welcome Dr. Deb. Dr. Deb, now you can share your screen now.
Thank you, Dr. Zeng, for the kind introduction, and I must acknowledge the invite extended by Dakewe and the entire team to facilitate me giving this lecture today and participate with a global audience. Thank you so much. So is my screen visible?
Yes.
I'll just convert it to the PowerPoint mode. So, coming to the human brain is an enigma, and diseases of the brain are actually something which is very interesting and exciting. So much of it is unknown till date. Right from 1979, WHO had endeavored to understand various diseases, the tumor diseases, neoplastic entities of the brain, based on various histological characteristics supplemented by immunohistochemistry and proliferation markers. The role of diagnostic pathologist had graduated and extended into a role where he was required to comment on the predictive, prognostic, and today be part of the journey of personalized medicine. Last 1 decade, there has been an explosion of molecular data. And this thing has gone because of the large scale NGS data which has been there. And today we have a whole lot of diagnostic, prognostic, and predictive markers that are available with us. Now, there has been a lot of transformation in concepts of tumors of the central nervous system. There have been major discoveries in biology of nervous system and which raise the question of incorporating non-histological data as molecular information. And that is the meeting at Harlem, where they questioned this. They wanted to see how it can be incorporated into the current concepts. The basic morphology, what we always knew, was a well circumscribed and diffuse glioma, which were two different types or entities. A diffuse glioma, what we know as WHO grade 2, diffuse astrocytoma, WHO grade 3 anaplastic, and WHO grade 4 glioblastoma. Now, what is a diffuse infiltrating glioma? This constitutes more than 75% of our neuropathology workload in any routine center. Now, it is something like this. The central tumor might be at one place, and tumor cells keep on diffusely infiltrating into distant areas. What is the implication? The neurosurgeon very seldom can achieve a total or near total resection in case of diffusely infiltrating gliomas. Hence, cells remain in the brain and they keep on progressing. Conventionally, what we know is there's increased cellularity, mitotic index, microvascular proliferation, and pseudopalisading necrosis. These are all the features we generally look into the morphology of diffuse gliomas. But when we come to the pathways, there's a glioma precursor cell which undergoes mutation. If there's a ATRX P53 IDH1 mutation, it goes into grade 2 and then progresses subsequently into grade 3 and secondary GBM. On the other hand, P10 and EGFR pathways converts the precursor into a primary GBM. On the other hand, if there's a IDH1 mutation with 1p19q co-deletion, that leads to oligodendroglial tumors. I'm sure the august audience is well aware about this. And that is why WHO 2016 recommended IDH1 mutation, ATRX, P53, 1p19q co-deletion as markers to assess what is the type of tumor, what is the type of glioma that we have. Is it a primary or secondary GBM? So what they did was they integrated for the first time phenotypic and genotypic parameters, and it was with the intent to add objectivity and greater diagnostic accuracy. It had a role in prognosis because there was more accurate determination, and also identified the subset of tumors which would be good therapeutic targets and have better outcome. This is Armed Forces Medical College, Pune, from where I graduated and post-graduated in pathology. Coming to IDH1 mutation, the primary cornerstone of glioma and the entire concepts that we have today. So in IDH1, we have the gene on chromosome 2q33.3, which encodes the isocitrate dehydrogenase pathway. And this is seen in grade 2-3 gliomas and secondary GBMs. It has a use in diagnostic and prognostic role, and possibly the single most prominent prognostic factor for overall survival after histopathological grading. We know that IDH mutant gliomas have a better prognosis than the wild type. That is the cornerstone of today's lecture. That is, IDH mutant gliomas have better outcome as compared to IDH wild type gliomas. And we can detect it either using immunohistochemistry, using the specific clone IDH1 R132H clone, which shows 100% concurrence with sequencing. And in cases which are negative by IHC, then we can do a DNA sequencing for IDH1 and IDH2 mutation. Coming to IDH2, this is rarer than IDH1 mutation and covers approximately 5% of all IDH mutations. And it is seen at R172. It is encountered in cases of astrocytomas, oligodendroglial tumors, and few of the glioblastomas. This is what a staining of R132H clone antibody looks like. It is very important in any brain biopsy. Why is it so? Because you can identify whether there's a tumor at all or not, especially if there is a stereotactic biopsy or a small biopsy. It might be very challenging to comment on that. Next, whether it's a glial neoplasm or non-glial, whether there's a benign or malignant glioma. And finally, where is the infiltrating part of the tumor, which I told you, diffusely infiltrating very far side from the primary tumor, also may have glioma cells. And that is why IDH1 is extremely important for assessment. In oligodendroglial tumors, these clear cell tumors also can be IDH1 positive. And how is it important in our day-to-day practice? The IDH1 negative clear cell tumors are neurocytic neoplasms, DNET, clear cell ependymoma, clear cell meningioma, various metastases, and the list actually becomes endless. So, if you see between how to differentiate between WHO grade 2 and 3 anaplastic and diffuse astrocytomas, great majority of them are IDH mutant, but we might consider a differential of GBM in case of anaplastic astrocytoma. In such case, we have to do a clinical and radiological correlation and supplement with FISH for EGFR and PTEN deletion. So, although IDH negative or IDH wild type diffuse astrocytoma and anaplastic astrocytoma are rare, but they are frequently encountered. And that is where the question comes about the pitfalls of WHO 2016. This is Command Hospital, Pune, another place where I had trained. Now we come to ATRX mutation. This is located at XQ210.1, which is involved in chromatin remodeling, histone regulation, nucleosome assembly, and it is very important because mutations in ATRX have strong correlation with astrocytic tumors that harbor P53 and IDH mutation. So basically, any tumor which has a triad of ATRX, P53, IDH mutation will be an astrocytoma. And it is not seen in any oligodendroglial tumors, and so is mutually exclusive with 1p19q co-deletion. And how do we detect it? Most easy way is immunohistochemistry, where we have internal markers in terms of endothelial cells or native glial and microglial cells which can be there. So ATRX is seen frequently in grades 2 and 3 astrocytic and oligoastrocytic tumors and secondary GBMs, and has significant overlap with IDH1 and TP53 mutations, which is very important. And we come to P53 mutation. This is mutually exclusive with 1p19q co-deletion in glioma, which is a molecular signature of oligodendroglial tumors. So P53 mutation shows close relationship to ATRX and IDH mutation, and what I said in the previous slide, coexistence of these three mutations are viewed as a molecular signature of astrocytoma. This is a very important concept for day-to-day sign-outs of our reports. P53 mutation characteristically is done by using immunohistochemistry. It's a very commonly used IHC marker, and it really helps to differentiate astrocytoma for oligodendroglioma, not diagnostic, but at least gives an indication. Next, if again there's a small stereotactic biopsy, P53 helps to identify the tumor cells within that biopsy. And again, in areas, the tumorous area versus the normal white matter can be distinguished by P53. Now, LOH1p19q, this is the molecular signature for oligodendroglioma. It is very important and has been path-breaking because it is not only associated for diagnosis, but also helps in prognosticating the patient because it has got a better outcome and also is a very strong predictor of sensitivity to chemotherapy. Commonly, FISH is fluorescent in situ hybridization with markers which are commercially available, is used for routine evaluation. PCR-based loss of heterozygosity is a bit cumbersome, bit time taken, but yes, this is something which has been used and also is better, I would say, as compared to FISH. This is how 1p19q co-deletion looks on FISH. And various studies which have evaluated or assessed the role of oligodendroglioma, which was and correlates the outcome with 1p19q. It is seen that 1p loss is a stronger marker than 19q, and in absence of both these, the prognosis or outcome or overall disease-free survival is much less, significantly less as compared to either or both loss of 1p19q. So effectively, in the assessment of a glioma, what do? We do first an IDH1, and if there's P53 mutation, loss of ATRX, that is mutation, it is an astrocytoma. If there is an 1p19q co-deletion, it is diagnostic of oligodendroglioma. This is how routinely we have been going after CNS WHO 2016. Now, oligoastrocytoma is an entity always difficult to define, has high inter-observer discordance, and although we try to use IDH, ATRX, P53, and 1p19q panel of these markers, most of the time they are compatible either with an astrocytic tumor or an oligodendroglial neoplasm. So the entity itself is a bit controversial. This is All India Institute of Medical Sciences, New Delhi, where I trained in neuropathology way back in early 2000. Coming to glioblastoma, this is a characteristic palisading necrosis, pseudonecrosis, and this is what there's a vascular proliferation, glomeruloid proliferation, which is there. But way back in 2003-04, we did a study. We found that glioblastomas have long-term survival. We had patients who survived about 15 years also. It puts the basic premise or hypothesis under a lot of cloud. Is it that morphologically, whatever looks as glioblastoma is glioblastoma ultimately a dumping ground of putting morphologically similar neoplasms? And does it actually require a deep diving into it? So, based on WHO 2016, where they integrated the molecular parameters also, it was found that GBM IDH wild type were the primary or 90% cases, and only few cases were IDH mutant type. And but majority of the sign outs in most institutes were happening as GBM NOS because even in many cases IDH evaluation were not being performed. So ultimately, the markers recommended for evaluation of GBM was IDH mutation, especially in less than 55 years, MGMT promoter methylation, TERT promoter mutation, BRAF for epithelioid glioblastomas, that is BRAF 600E mutation, histone H3K27 mutation for diffuse midline gliomas. This is MGMT promoter methylation. MGMT is a gene located at chromosome 10q26, which encodes for the DNA repair enzyme O6-methylguanine DNA methyltransferase. Why this is important is because this enzyme ensures rapid repair of DNA and makes the cell more resistant to alkylating or methylating chemotherapeutic agents. Epigenetic silence of this gene by promoter methylation has been found to be an independent prognostic marker because that has been the base for starting chemotherapy in terms of temozolomide in all these cases. We can detect MGMT using methylation specific PCR and pyrosequencing, and it is imperative that all these new high grade gliomas should be evaluated for MGMT epigenetic silencing because we can give them temozolomide. And as all studies subsequent to that, which we all know that cases which have received temozolomide and especially temozolomide with radiotherapy have had a very good outcome. In cases of GBM, when were discussing in terms of survival in months, 10 to 12 months after diagnosis, with radiotherapy and temozolomide, it extended even to 4 years, 5 years, and disease-free intervals. And there was a much better overall survival in patients who received these treatments. This is the Institute of Neuropathology, University of Heidelberg, Germany, where I had my initiation into molecular neuropathology under Professor von Daimling. This brings us to V600E BRAF mutation. Conventionally, it was used in cases of PXA and less often in diffuse adult gliomas. But with the identification of epithelioid glioblastoma, which is a very aggressive tumor, it was understood that V600E mutation needs to be evaluated either by IHC or RT-PCR. So this is what it looks like. The tumor are epithelioid cells, highly aggressive, especially in children and young adults, seen in the superficial cerebral mass and has an aggressive course with rapid dissemination in leptomeninges. This is the IHC profile. And as you can see, V600E mutations in various studies have been varying between 50s, around 50s to 60% of the cases. It has a huge therapeutic implication. There's a dramatic response to BRAF inhibitors in these cases, which we have personally encountered number of cases and also number of case reports and series have been there, which have said that in cases of epithelioid GBM, there is a need to assess for BRAF V600E mutation. So when we are at pediatric neoplasms, it was soon identified and understood that pediatric GBMs are just not to be treated as GBMs of little people. They are something which are biologically and clinically defined subgroups. They have distinct copy numbers, gene expression, and they are ones which have a distinct tumor biology. They are all linked to somatic histone mutations, and H3.3 G34 is one which is seen in cerebral hemispheres. 3.3 K27 is midline gliomas, and 3.1 K27 is in the pons. So coming to H3 K27 mutation for what used to be called as diffuse intrinsic pontine gliomas or the midline gliomas. So today, any midline tumor needs to be assessed using this marker. It can be evaluated using immunohistochemistry because any of these tumors which has K27M mutation has very poor prognosis with aggressive outcome. Survival in 2 years, survival rate is less than 10%. These midline gliomas can have varied morphology. They can have a pilocytic-like areas, hyalinized blood vessels, oligodendroglial areas, peanut-like morphology, giant cells, or epithelioid cells. So all these varied morphology has one thing that all of them are located in the midline region. So midline gliomas need to be assessed using H3K27 mutant markers, and with simple immunohistochemistry only, they can be assessed quite reliably in routine diagnostic lab. And why is it required so? Because there are new targeted therapies which are being developed for diffuse midline gliomas with histone H3 gene mutation. The HG3.3 G34 mutant glioma is again a IDH wild type glioma of the cerebral hemisphere. It is found in pediatric and young adults, distinct from the conventional IDH wild type of mutant gliomas and the H3K27 mutant tumors. It has distinct astrocytic differentiation with mitotic activity, microvascular proliferation, with or without necrosis. They are positive for, with immunohistochemistry, they are positive for the marker H3.3G34, negative for OLIG2, has ATRX lost, and P53 positive. This is the DKFZ of University Heidelberg, and this is the major cancer center associated with the Institute of Neuropathology, Heidelberg. Now, what were the pitfalls of WHO 2016? Most important is the molecular classification of glioma. It was found was highly relevant, and many patients were now considered to be included in clinical trials of drug-targeted therapies. There were accurate classification system which took into consideration of the molecular characteristics of CNS tumors for accurate diagnosis, prognosis, treatment selection, and enrollment into relevant clinical trial. For the first time, it was seen that the integrated molecular characteristics and histological features, what I enumerated, were seen together, evaluated together. But still, there was a legacy of grading system which was there, was very subjective. And this missed out a lot of distinct tumor entities. Risk stratification was not satisfactory. Again, most important was these molecular markers which were used in diffuse astrocytic gliomas. It was seen that if we do not assess for those, it can be missed out. So there were a lot of dilemmas. How can various non-histological criteria like molecular, imaging, and clinical be used to enhance the typing and grading of brain tumors? What is the relationship between diagnosis and grade? Like what I showed you, the morphology might be that of glioblastoma, but patients are surviving 10 years, 15 years? Is there something that we are missing? Next, what is the recommendation of use of molecular testing? Discrepancy between morphology and molecular feature, role of radiology and clinical parameters. All these things were missed out in the recommendations of 2016. So it was thought that in order to define and identify distinct entities, okay, we needed to fine-tune various interobserver variations, clinicopathological predictions, and have a better therapeutic planning and diagnosis of tumors. There should be an integrated diagnosis incorporating histological, WHO grade, and molecular information. We must endeavor to identify key molecular information for tumors, based on mostly in gliomas, because that would have a direct connotation on the outcome and treatment of tumors. Pediatric and adult tumor had to be dealt differently, and the importance of multidisciplinary approach, clinical, radiological, as well as incorporating molecular doing specific testing and incorporating molecular data in the diagnosis. So this set the stage for WHO 2021, where international group of leading neuropathologists and neuro-oncologists, they got together to form a consortium to inform molecular and practical approaches to CNS tumor taxonomy, which is called 𝐆𝐸 Now. There have been various updates on 𝐆𝐸 Now, and over the years, it has been refined. Few of the highlights of the recommendation was that for diffusely infiltrating gliomas, which was IDH, wild type and mutant tumors, they represent distinct clinical and genetic entities, and to reserve the term glioblastoma for these diffusely infiltrating astrocytic gliomas that are IDH, wild type, WHO grade 4, which has a ATRX loss and P53 positive markers. Next, there's a substantial subset of IDH wild type, grade 2 and grade 3 gliomas in adults, which, because of their wild type molecular nature, was associated with aggressive course, which was very similar to that of IDH wild type glioblastoma. Next, lack of IDH mutation alone was insufficient for designating a glioma as WHO grade 4. Now, there are certain glial and glioneuronal tumors which were IDH wild type but had a very favorable biology, like ganglioglioma, pilocytic astrocytoma, PXA, and pediatric low-grade gliomas. So it was important that implementation of molecular markers in diffusely infiltrating gliomas and these astrocytomas grade 2 and grade 3 is essential for understanding these tumors. However, there were certain of these tumors, IDH wild type gliomas, which had TERT promoter mutation, EGFR gene amplification, or chromosome 7 gain and 10 loss. So the question was, are we looking at a molecular type of glioblastoma? These are diffuse astrocytic glioma of IDH wild type with molecular features of glioblastoma. If they had microvascular proliferation and necrosis, we would have immediately termed it as glioblastoma. But if it was an inadequately sampled glioblastoma without these morphology, then we might be incorrectly labeling it as a grade 2 or grade 3 tumor. And that is why we had to do, the recommendation came that TERT EGFR or chromosome 7, chromosome 10 analysis needs to be done. So how do we do a EGFR gene mutation? It is using the EGFR variant 3 mutation. It was understood which plays significant role in gliomagenesis, and that is either assessed using FISH or IHC using antibody specific to EGFR variant 3 region, or finally, in case of controversial entities, by PCR sequencing. The other marker which was recommended was TERT promoter mutation, which is located on chromosome 5p 15.33. Telomerase, as we know, prevents telomere erosion associated with cell division. It was understood that these tumors, which are detected using Sanger sequencing, were associated with shorter overall survival and was documented in about 80% of primary GBM. And that is where it was understood that this is a very important marker for identifying or labeling, molecularly labeling a tumor as a glioblastoma. And as it can be seen that wherever TERT promoter mutation is there and one where there's no mutation, the overall outcome and survival in the patients was very, very different. See, IDH mutant and TERT mutant has a very good outcome, whereas IDH wild type and TERT mutant has the worst outcome in all the subsets that were there. So one of the study evaluated TERT promoter mutation with ATRX mutation, and they found that TERT promoter mutation, although had favorable outcome in oligodendroglial tumors, but in gliomas, be it IDH wild type, grade 2 or grade 3, or IDH mutant GBM or wild type GBM, it had unfavorable outcome. Independently associated with favorable outcome in IDH wild type GBM was ATRX mutation. And it was understood that both these parameters need to be evaluated to fine-tune the overall outcome of these tumors. This is Kaman Hospital, Udhampur. Again, my first place where I started off my independent neuropathology practice. Now comes to the C-Impact Now 5 recommendation. Now, it is the one which recommended grading and nomenclature for IDH mutant astrocytic diffuse astrocytomas. Conversion to a single name, astrocytoma IDH mutant. Next, Arabic numeral grades were assigned 2, 3, 4 instead of the Roman ones, and discontinuation of the term glioblastoma. Basically, this dealt with the concept of astrocytoma grade 4, which is one IDH mutant type, and glioblastoma, which is IDH wild type. And it also recommended retention of histological features, that is, significant mitotic activity is grade 3, microvascular proliferation with or without necrosis grade 4. In addition, it introduced a new genetic marker, CDKN2AB homozygous deletion, which is extremely important in understanding concept of grade 4. Basically, IDH mutant astrocytoma, which was thought to have a very good outcome as compared to IDH wild type ones, if there was a CDKN2A or B deletion, it meant that it was equivalent to a grade 4 tumor. And various studies from UCSF, they evaluated various cutoffs. Initially, the cutoff for fish was told to be at 20%. So these are various cutoffs which were there, because to have a better assessment of CDKN2A, we need to know what is the cutoff. Otherwise, from center to center, there would have been a lot of variation. This was from Shriata et al. In 2018, where again they evaluated the impact of CDKN2A and with overall survival, and they found that it is one of the most powerful parameter for inferior clinical outcome in anaplastic astrocytoma and GBM. This is a study from All India Institute, Delhi, where they found a significant association between CDKN2A deletion and P16 immunonegativity. for the predictive value of immunohistochemistry. It was a very good study which gave a good insight into the role of CDKN2A in gliomas, high-grade gliomas. Again, from University of Pittsburgh, they evaluated and assessed using fish in grade 4, and they found that it's a definitive criteria that it has a better outcome. They recommended a cutoff of 30%, and they observed that it is rare in primary tumors, more frequent in recurrent tumors, significantly stratified survival of grade 4 tumors, and generally grade 2 and 3 tumors did not cross the cutoff of 30%. So once we see what different groups have assessed CDKN2A cutoffs, it ranged at an average between 25 to 35%, which has been there. And overall, it has been depending on the type of method that has been done. There has been a cutoff which were being reported by various groups. So overall, what did they summarize? They said, okay, if there's a glioma, first do a panel with ATRX, IDH, P53, 1p19q co-deletion. If IDH is mutant, look for ATRX. If it's retained with 1p19q co-deletion, it is oligodendroglioma. If IDH mutant ATRX loss and CDKN2A also deletion, it is IDH mutant astrocytoma grade 4. But if there's no deletion of CDKN2A, it is IDH mutant astrocytoma grade 3. Whereas IDH wild type tumors should undergo EGFR, chromosome 710, and TERT promoter mutation. If all are positive in at least one, it becomes IDH wild type glioblastoma WHO grade 4. Otherwise, it is retained as IDH wild type diffuse and anaplastic astrocytoma WHO grade 2 and grade 3. Army Hospital Research and Referral, Delhi, is one of the premier institutes of armed forces in India, and this is where I developed neuropathology to a great extent. Coming to 𝐶IMPACT now 6, diffuse astrocytic glioma IDH wild type with molecular features of GBM. Basically, again, if they say that if there's a TERT promoter mutation, EGFR or 7+10-, it becomes a molecular GBM. This concept of molecular glioblastoma was very important because it was found to be a distinct entity seen with a mean age of 36 years, predominantly frontal in location, and overall survival more or less equivalent to IDH wild type glioblastomas. So even if it is any grade, conventionally grade 2 or 3, but if there are any features, molecular features of GBM, it immediately goes to a higher grade and needs to be treated like glioblastoma. So the important considerations in 𝐶IMPACT now, whether or not morphological grade 2 IDH mutant tumors will require CDKN2A testing for formal grading. That was very important. And to understand testing of grade 2 tumors for deletion, what are the challenges related to it? Because every institute might not be having this facility, and there would be an undue financial burden on the global healthcare system to do such an extensive workup. This is Command Hospital, Kolkata, again, where I practiced neuropathology. Now, the Harlem Consensus of the International Society of Neuropathology was one of the major turning points to adopt molecular classification. And that is where this integrated diagnosis report format was proposed where it was a layered report format, which is to be given nowadays. That is an integrated diagnosis, first layer. Second gives histological diagnosis. Third is WHO grade. And fourth is the molecular information. Unfortunately, if a particular center is not doing molecular studies, they should leave it at a histological classification with a WHO grade and write as NOS only. This is at SRL Diagnostics, Mumbai, where I was heading one of the largest corporate diagnostic labs of India. Now, this brings us to WHO CNS 2021, which is built up on the 4th edition. It has the specific recommendation. Now, briefly going through all this, this is all the brief overview of the new entities, what is there in WHO 2021. And the salient features are, in this recommendation, molecular subgrouping has been shown to be superior to histopathological grading, and molecular markers now prevail over histopathology. There is a recommendation for methylome profiling, but again, there's a optimal methodology and limited diagnostic test availability is one which is restricting it. Otherwise, this is a very powerful tool for classification and diagnosis of CNS tumors. Currently, they are being referred to as tumor types. The entities, what were there in WHO 2016, are called tumor types, and variants are now called subtypes. And interesting to know that here it has moved to a within tumor type grading system. For example, what I said already, astrocytoma IDH mutant can now either be grade 2, 3, or 4, and the term anaplastic is no longer to be used. Coming to glioblastoma, again, reiterating that loss of 10, gain of 7 chromosome, EGFR amplification rearrangement, P53 mutation, P10 mutation, third promoter mutation, all these, at least one, would lead to a genetic event and a genetic signature. IDH wild type diffuse astrocytoma or anaplastic astrocytoma, okay, shares signature genomic alterations very similar to primary GBM. These tumors possibly represent undersampled glioblastoma, even if morphologically they do not have all features of GBM. Prognosis and therapy, that is why, is similar to glioblastoma. IDH wild type diffuse astrocytoma or anaplastic astrocytoma is without the genomic alteration of glioblastoma. This is a rare entity and not considered a tumor type. And if something like this is encountered, it should prompt additional molecular testing in form of BRAF alteration, histone mutation, and most important, methylome profiling for a specific diagnosis. In contrast, we have the IDH mutant astrocytoma, which in 2016 required presence of IDH1 or 2 mutation along with 1p19q co-deletion. However, since 1p19q is quite expensive to do and requires a more specialized setup, in 2021, it says that loss of ATRX and or TP53 mutation along with absence of presence of IDH1 is enough. One need not do LOH1p19q testing. There's a need to integrate histopathological criteria with CDKN2A status because one can convincingly diagnose a tumor as IDH mutant grade 2 or grade 3 or grade 4, provided there is a homozygous CDKN2AB deletion. So testing for homozygous CDKN2AB deletion is critical for accurate diagnosis, prognosis, and counseling in IDH mutant diffuse astrocytoma. Interestingly, it was observed that there was radiotherapy was associated with acquired CDKN2A deletion at recurrence, and this was linked to worse survival. So all recurrent gliomas need to be tested for CDKN2A to understand what is the implication and how aggressively the tumor needs to be treated. So, as I have already covered, these because of all these conceptual changes, so there is a change in nomenclature of 2, 3, 4, and optimal workup would require that if initial evaluation is consistent with IDH wild type without high grade feature, perform NGS or copy number profile for EGFR, TERT, and gain or loss of 710, because all this will shift it to grade 4. And in the presence of diagnosis of glioblastoma WHO grade 4, evaluate for MGMT gene promoter methylation, because temozolomide is a very strong treatment modality that we have today. In case of IDH mutant astrocytic gliomas, it can be established using ATRX and P53 expression as surrogate IHC markers in absence of 1p19q correlation availability. But CDKN2A deletion has to be done because presence of this molecular alteration makes the tumor grade 4. And that is how WHO 2016 looked like, quite simplified, but WHO 21 essentially needs a IDH, needs subsequently 1p19q ATRX, and evaluation of all the markers for GBM and also CDKN2A, because without that, optimal workup cannot be done. These are the key genes. I'm not going to the details of it. Depending on the tumor type, it has been very nicely summarized by the article by David Louis and Ari Perry, where they have very nicely given all the pathways which would require a detailed discussion of each of these pathways. These are the newer gradings of tumors in WHO 2021, some of the newly recognized tumor entities, and tumor types with revised nomenclature which have been there. This is again another center where I developed digital pathology and molecular genomics center in Mumbai. Some of the new entities which have come is polymorphous low-grade neuroepithelial tumor of young or plenty, diffuse hemispheric glioma H3G34 mutant type, myxoid glioneuronal tumors. So these are things which might overlap morphologically with our well-known morphology, what we were used to previously, but all these requires detailed discussion and detailed evaluation. This is currently where I work at Aster Labs, Bangalore. So again, a simplified algorithm for a diffuse glioma workup, but as it can be seen, all these require a very specialized setup and is quite an expensive workup in most of the resource-constrained scenario. It's easy to say and discuss about IDH1, LOH1p19q, ATRX, H3K27M mutations, but there's a question in the global perspective of the cost, affordability, need for a specialized center, specialized team has to be there, equipment has to be there for assessment and evaluation. The team has to be very well specialized and experienced into each of these markers. Otherwise, if at the very basic IDH1 assessment is incorrect, okay, the entire algorithm goes wrong. And obviously, there would be a longer turnaround time for workup of these cases. So this is a recommendation given at the consensus in the Indian scenario, where based on IHC for IDH1 R132H clone, along with ATRX and limited FISH. Okay, and in very few cases, IDH sequencing, one can have a proper workup, at least to observe whatever were the recommendations of WHO 2016. And to summarize, the various IHC markers that I have been mentioning. These are the various IHC markers, the interpretation, how to see it, whether it's a nuclear, cytoplasmic, and what is the generally recommended or standardized clone that is being used. And here, these are the new markers, ones which are done by FISH, and the cutoff using which clone, and the other ones for one which can be done using Sanger sequencing. So to conclude, it is critical for pathologists to recognize the diversity of molecular testing available, know which test to order, when to order, how much workup should be done, and which are the cases where molecular data would be helpful to the patient is a very important decision to be taken by the reporting histopathologist. New technologies needs extensive adaptation to current clinical practice, how we report out. In places that do not have access to such technologies, it's okay to use NOS labels generously and pass on the case to a higher center for a better workup. And there's a need to improve the molecular detection methods with clear and specific description of algorithms and have optimal evidence-based, balanced, rapid translation of novel insights into clinical diagnosis. Adoption of CNS5 into clinical practice will facilitate accurate diagnosis, improve management, and optimal outcome of the patient to include in various clinical trials. This also has important implications for design, implementation, and interpretation of clinical trials. However, logistical and financial considerations of molecular testing are the major impediments which will change timelines for patient enrollment, availability of clinical trial sites, and reduce the enrollment into the patients into all these studies. However, improved definition of disease entities will lead to design of more specific therapies and prevent potentially confounding effects on response and outcome when histologically similar but molecularly distinct tumors were studied together in the past. My gratitude to all the different centers where I have learned and practiced and learned during practice neuropathology in all my past about 20 years into neuropathology, 30 years into histopathology. Thank you so much for your patient hearing. And Dr. Zeng, if we can have any questions or any clarifications, please.
Okay, that's great. Thank you so much, Dr. Deb, for your wonderful and informative talk. What you said is true. The new WHO classification of CNS tumor is a great progress in accurate brain tumor diagnosis and guiding the clinical treatments. There are, however, really posed many practical challenges to our neuropathologists. Many labs have very limited tools. For example, even in my lab, initially only have GFAP antibodies, and we don't have IDH antibody until last year. So, many other hospitals have to send FISH testing or NGS to outside reference labs. So, which of course are going to affect our turnaround time and increase the medical bills or patients' insurance, all kind of additional work for the neuropathologist.
Agreed.
So it is
absolutely well, correct. Because I am quite concerned with the concept of diffuse astrocytoma, which is IDH wild type. Now, is it a molecular GBM? So I might just sign it off. Okay, even with an IDH also, okay, that can flag it, that it is a wild type, so some more work needs to be done. But again, centers are few, people to interpret are very less, there's a long turnaround time, and it's very expensive also to do it. So many people shy away. That's a practical problem what we encounter. Okay, and if somebody has not done an IDH also, might be falsely feeling safe that it's a grade 2 tumor. The neurosurgeon is also very safe, neuro-oncologist also feels very good, but there's a recurrence and they wonder why there's a recurrence. Today we know that it is not actually grade 2, it can be a molecular glioblastoma.
Exactly. Yeah, and actually, I had pretty interesting cases. And first, I want to ask you: do you guys use DNA methylation profiling test in India?
Yes. For all our GBMs that we sign out, or at least high-grade gliomas, I personally ensure that the patient goes for methylation profiling. Because it makes not as a routine thing, but at least there are people who are willing to go and do a full profiling also. Okay.
Yeah,
But otherwise, routinely, what we do is how I practice is first the glioma panel IDH1, P53, ATRX, 1P19Q. Okay. And KI is definitely, KI67 is definitely there. I use it as a thumb rule for all my cases. Okay. And then if it turns out to be a high grade glioma or it is GBM, going for a MGMT analysis is definitely to be done. And cases where we find that it is not matching into the clinical suspicion, clinical radiological profile in a tumor board, it is there, then it is recommended to go for a profiling.
Yeah. So all those molecular features, sometimes if we don't understand them very well, it could be misleading. The cases that I had recently actually is like a young women temporal lobe tumors that on H&E looks like a low-grade gliomas, more like PXA kind of appearance with EGBs, and Ki67 very low, like less than 1%. So IDH wild type, of course. And then it was sent to NGS, and then came back as have TERT promoter mutations.
Exactly. That is exactly what I'm saying. It is and a young person, So I feel that it should be made imperative and possibly overall the cost liability, the testing cost should be reduced, or somewhere we have to, as a global thing, has to be reduced, because a young life getting lost because otherwise you would have said, okay, a low grade and taken it out. If you had not sent for a dirt, okay, it would have got missed out.
Yeah, so there is some turnaround for this case. So in addition to TERT mutation, that case also have FGFR TCCA3 rearrangement. So the clinician initially treated this patient as IDH wild type molecular GBM, as we mentioned, because IDH wild type TERT promoter mutated. So, but then the patient went to MSK and did the methylome analysis. So the newest methylome classifier actually put that tumor into outlier of low-grade ganglion glioma categories. So they eventually think, well, the FGFR TACC, that fusion might be the driver mutation for this tumor. Okay. So they think probably this tumor won't really behave like as aggressive as IDH wild type GBM. Probably will have a little bit better prognosis. However, might have more aggressive behaviors. So the example for this one is just mentioned.
Actually, overall, the data on all these newer markers is so less. And now that with C impact now, people have been accumulating the data and following up the patient, because unless and until high-grade glioma with the temozolomide, you would have a 2 to 3 years data with you. But other low-grade gliomas or low-grade neoplasms, you need at least about 4-5 years data. Otherwise, all these are might seem very interesting, might seem there, but again, the question comes is with this coming into the WHO, and there are certain strong evidence supporting them. Okay, so do we overlook them? Do we really do not know how the tumor will behave, because there are so many different pathways, so many different driver mutations. At times, we are really not very sure how it is going to go ahead. It's only time will say how it goes on.
Yeah, exactly. So like long-term follow-ups is probably the gold standards to tell us whatever we know so far, it is true or not. Yeah.
Yes, yes.
I also want to ask you some practical questions. ATRX, the antibodies, it's not working that well in our hand. I asked many of my colleagues in other hospitals. So a lot of time we just skip ATRX whenever we have a glioma, like show IDH positive. So we will send to 1p19q analysis either by FISH, most of the time by FISH, anywhere, regardless ATRX status. That's a tricky antibodies. Does it work well in your lab?
I mean, ATRX I've been using since past about 7, 8, or more than that, about 10 years I'm using. So again, it depends on the clone with which you're using, and I mean, the one with Sigma works quite well. And I mean, the best part of ATRX is, and all of my cases, I use a control along with every section that I stain. I use a control, so I know that whether it's working or not. Plus, ATRX, even without a control, the internal endothelial cells is the best thing to know that whether it has worked or not. Okay. And I mean, whenever we have tried changing the clone to a different clone, we had some problems, some issues which have been there. But overall, I'm quite comfortable with using ATRX in my lab.
I see. Yeah, sometimes in our hand, it has very brush stains. Although sometimes the endothelial cells works, but then the blush stains, you're not quite sure it is truly positive or negative. So, and that's why a lot of time we end up just don't look at the ATRX things.
Yeah, at times you actually have to look into the entire thing holistically. Okay.
Yes.
I mean, for me, before I look at my slide, I generally go through the clinical and radiological profile before I even get into the slide. Okay, because I mean, otherwise, many times it can misguide you. Just looking at the morphology, it might misguide you. Okay, especially if it is the biopsy has been taken from an area around the tumor. Okay, and then you have to get back. If you see the post-op images and you go back to the surgeon, the neurosurgeon will say, yes, there were certain issues by which we could not reach the tumor proper, maybe eloquent area or some issues we could not reach the area. So it is always better to look at the clinical part, radiology, discuss with them, and then okay, whether your IHC is working or not. And if you are using the same markers, if you have about 4-5 cases per day, and if you're using the same markers, I know, okay, my marker is working or not working. There are some challenges with any particular marker.
Yeah. Similarly, like P53, right? P53, when we're dealing with Jianying tumor, serous carcinoma, P53 mutant, we want to see like almost pretty strong diffuse P53 mutations. But then positivity, I mean, but you not always see similar patterns in the brain tumors. So what kind of in your experience, how much P53 positivity that you really consider might correlate with the molecular P53 mutation?
See, I have not really, apart from very few centers, I've really not correlated with the molecular P53 mutation. Okay. But, it's been quite some time. I had a very good correlation with the molecular P53 correlation. But, I would say that most of the workers who have been working on it that I know, the groups that I know, have had good correlation with P53, the antibody that they use, and the molecular correlation comes up pretty well. It's very few cases where possibly there's a miss, and there would be a requirement to do a molecular TP53 mutation analysis, but I really never have faced much of a problem in this.
I see. Okay. All right. So let's see. Lei, any question comes from the audience?
Well, Dr. Zeng, actually, we haven't received any questions from the audience yet. But we have a lot audience tonight. It's almost like 600 audience joined tonight's webinar. Yeah.
Yeah, of course. Neuropathology is very, very subspecialized things. A lot of general pathologists probably not feel very comfortable, at least in my lab, is like looking at the brain tumor cases. But there is a lot of changes, and that's the value for today's talk, that Dr. Deb gives a lot of molecular overview that has been dramatically integrated into the new WHO classifications. And a lot of things, even for neuropathologists, to learn that part. Yeah.
It's difficult for neuropathologists also to keep abreast with all the developments happening. It's too much of information and too fast for us. And that is why WHO has been coming up once every 10 years. But here, after 2016, in 2021, the next one came, CNS5 came in 5 years. So there's so much of development happening in neuropathology. It's really very, very fast paced that is going on. Too many things happening, actually.
Exactly. Unless in those big, large research centers, they will have all the IHCs, PCR, FISH testing, NGS already. But the majority of us general labs don't have every tools already. So, but however, the clinicians, they when they treat those patients, they really need those informations to know. Interesting things. I just record. You mentioned before, like epithelioid GBM. That patient, those patients often have BRAF V600E mutations, and then they can be treated with BRAF inhibitors. So all those information, it's a guidance for the clinicians, oncologists, for them. We had like 2 or 3 patients actually in the past few years that epithelioid GBM. Some of us think it's probably progression or arising from PXA and aplastic PSA, which also have BRAF V600E mutations. All those patients actually were given BRAF inhibitors. 2 of them have good prognosis. I think the follow-up we had it last year, at least they have lived for more than 2 years, 2.5 years. But the other one, I think, passed away probably in 15 months. So it's still kind of need a long-term data to really to see those targeted therapies truly effective, or maybe still any other underlying mechanisms.
In fact, this is a very interesting thing about epithelioid GBM. One of the case had tested positive for BRAF V600E and was given inhibitor and had a very, near total outcome. The tumor nearly vanished. Previously had mets in the spinal axis also.
Wow, similar case.
That entire thing disappeared, and for about 4 years, the girl was totally, disease free. For 4 years, leading absolute normal life, but now has got a recurrence again. Okay, and morphology is same as the initial one. So, any thought about this? What more can be done? Which markers can be done to understand? Because is it like what we know about BRAF inhibitors it is a double-edged sword. Okay, if something is positive, you give it responds very well. If it is not positive, you give it goes the other way. It progresses the tumor. So, is there something now that there's a recurrence? What more testing can be done? And are there any other therapies which can be offered?
Yeah, we don't know. So that's why probably the next molecular tools like a methylome. So sometimes to see if progressed tumors maybe going other ways.
Yeah, I know. Methylome analysis. Since I just mentioned that I have been trained with Professor von Deimling in Heidelberg. Okay, his group does a lot of work on methylome profiling, along with David Kapper, and his entire group does a lot of work. So, maybe there would be some answer if a methylome profiling is done in these cases. That what more can be done, because there are so many other targeted therapies, and if a different pathway is identified, possibly something can be offered.
Yeah, I think similar things happened in the melanomas. A lot of melanoma also have BRAF V600 mutations.
Exactly. Yeah,
it can temporarily, almost entirely wipe out the tumors, but later the tumor can come back. So.
Because is it that some other pathway gets affected after reaching a certain level, optimal level? Some other pathway gets activated, and possibly a methylome profiling would be able to identify that pathway. And if there are any clinical trials or anything going on with those pathways, maybe that can be offered to these patients who are a breakthrough of, BRAF inhibitor cases where there's a recurrence happens. So it is something which is a very gray area right now.
Yeah, exactly. But it's already great improvement, because IDH wild type GBM, we basically in the older time we consider just like a 1 or 2 year survival. So.
Yes, today GBM you talk in terms of 4 years, 5 years. Okay.
Yeah.
And as I showed in that article, which we published, that series, there were GBMs who survived 15 years, 10 years, 15 years. So that was when we always used to think. That was in 2003, 2004. So we were thinking, what is it that morphologically something is a GBM, but there's something else happening in the background? Why it is not? We're not able to square it off.
Yeah. Right, and that's how the meaningful things guidance from our new differential classifications of brain tumors.
Exactly.
Okay, that's great. I learned a lot. Thank you so much.
It's always a learning experience to talk to good neuropathologists like you. You're also working quite well in this field.
Yeah,
always
exactly.
Nice.
Our clinician also say, wow, it's all new learning field. Yeah.
That's wonderful. Well, thank you, Dr. Deb, and thank you, Dr. Zeng. We would like to really appreciate your time. It's like more than like 1 hour to share your experience, and we really also really like to thank Dr. Zeng for hosting tonight's webinar. So yes, I think our audience will learn a lot from today's lecture. I think almost time to end tonight's webinar, and we would like to thank you to all the audience who joined us today, and we hope you will continue to follow in DDCE in the future, so as we will bring you more exciting presentation and knowledges. So yeah, thank you.
Thank you so much. Pleasure
Thank
to be
you very much.
Thank you.
All right.
Thank you.
All right.
Have a nice day, guys.
Thank you.
Yeah, you too.
Bye.
And have a nice have a good time for the rest of the weekend. So really appreciate you spend weekend time to share the knowledge with us. Thank you. Have a good day.
Thank you so much. Thank you.
Okay.
Have a great day.
Thank you.
Bye.